hemisphere versus left hemisphere also. The right hemisphere of your brain affects the left hemisphere of your body. The left hemisphere of your brain affects the right hemisphere of your body.
Right.
Can a bunch of TIAs also lead to
Yes.
that? Because I saw that in somebody.
So the after effects of massive stroke can include motor disturbances and can also like paralysis or hemiparesis. You might see people with left side paralysis if they've had a right brain stroke, or left side paralysis, or the opposite of what I just said. Can't remember which one I just said. So let's cross over. One of the things, and so we see lots of people walking with a quad cane, hemiparesis, and we know, oh, that's probably a stroke, right, or a brain injury. And a lot of times people who've had a massive stroke, who've gotten the rehab that they need, can get really, really almost back to normal. And doctors might sometimes tell the family, 100% recovery, it's a miracle. But most of the time there are residual effects that aren't always tested for, that affect personality changes, emotional changes. Emotional changes after stroke are huge. If I sit down, can everyone sit down along with me? I'm going to sit for a little while. Emotional changes are huge after stroke, and they're not always assessed. They're not always acknowledged. And so the family is left feeling like Dad had this stroke and now he gets to be a jerk, and we don't understand why. Or Mom had this stroke and ever since she's just been this puddle of tears all the time. She just self-pity. Because lots of times if it's not assessed and the medical community doesn't acknowledge it, then the family doesn't have a context for that, even though it's a normal after effect of stroke. Depression is a normal after effect of stroke, and it should always be assessed. They're getting better and better about that. We also sometimes see what we call emotional lability, which is that emotional roller coaster. Labile means quickly changing. So if there's emotional lability, they could be happy 1 second, angry the next second, crying the next second, the drop of a hat. And sometimes, I think the stress and the grief and the loss does play into it. But there's also a physiological component to those emotional disturbances caused by stroke. So that's a big one to be prepared for if you're going to someone's house who has stroke-related dementia. You might be prepared for some of that emotional roller coaster. Doesn't mean it's necessarily going to happen, but you might be prepared for it. So that if and when it does happen, it doesn't shock you. Oh, I've got a context for this. They've had a stroke. This makes sense. Is that helpful? So massive strokes, there are three different types of stroke. There's thrombosis and embolism, which have to do with blockage and clots disrupting the blood flow to the brain. That's what a stroke is. It's disrupted blood flow to the brain. So thrombosis and embolism have to do with clots or blockage. The third type is a hemorrhagic stroke, or sometimes we hear it called an aneurysm, where it's actually a bleed in the brain. And most of you are probably familiar with new protocols around getting attention to someone that you think might be having a stroke, right? Have them stick out their tongue. Is it crooked? Have them lift both arms. Can they do that? Is their speech slurred? Do they have a droop on one side? Those sorts of things. Yeah, the smile. And get them to an emergency room as quickly as possible, like within the hour. The reason for that is because we now have really, really great super anticoagulating medications that can help bust up a block or a clot really quickly and help lessen the after effects of that stroke. Because the after effects also depend on the extent of damage, right? So location and extent. So we can get someone in and get them that medication in enough time, we might prevent further damage because we can get that blood flowing.
That happened to a friend of mine, quick response. I mean, she couldn't talk, and her husband took her to the hospital. They met and went off to the hospital and had that procedure, and she went back to work as a social worker.
Great,
Yeah.
great, yeah. So it's really good that the word's getting out there. We're calling it more, treating it like a brain attack, the same way we would treat a heart attack. It's basically the same kind of thing going on in your brain. The reason we need to do that is because there's only a specific window of opportunity. I think it's the first 3 hours after stroke that you can use those medications. So if you get someone there later, it won't be helpful. You got to try to get them within the first hour because they have to have some testing done to determine what type of stroke they've had, because if they've had an aneurysm, we don't want to give them super anticoagulating medication. They'll bleed out. They'll make it worse. So we want to get them there as soon as possible to identify what kind of stroke they're having, and if it's treatable, they can treat it within that window of opportunity. So again, not something that we're going to be pressuring families to do, but you might have somebody you're working with, you might be in someone's home and notice and need to take quick action. Also, this you might happen with someone in your family as well. So we want to make sure people understand why it's so important to get people emergency help. So the other type of stroke-related dementia is the vascular dementia caused by mini strokes, or TIAs. That stands for transient ischemic attacks. I'm sorry, one more time. TIAs are transient ischemic, ischemic attack. And these are those little mini strokes. So as opposed to Alzheimer's disease, which kind of has a trajectory that's all over the map, affects the whole brain, right? With stroke, we're seeing after effects depending on location and extent. And with the little mini strokes, the dementia is caused by the accumulation of damage. So it's mini assaults over and over and over and over and over and over again. So we see progression that looks more like a stair step, right? So somebody's baseline functioning is here, then they have some TIAs and it drops to here. But then it plateaus until they have another TIA, and plateaus until they have another episode.
Over a period of days, weeks, months?
All of the above, just depending on how it happens, right? So could be they had a TIA and they never have one again. Although if you've had one, your chances for having another one are greatly increased. Could be they have a couple of TIAs and then they have a couple of TIAs 5 years from now. Could be they have 10 in a day, depending on what's going on with their vascular structure.
The body symptoms the same for the TIAs as they are for a full stroke? The slurring the tongue?
You might not notice that. No, you might notice somebody kind of blank out a little bit and then come back. Or she just kind of drooped a little bit, or she leaned to the side, or she stared for a few minutes and wasn't responsive.
How about fainting, completely just passing out for, say, 5 to 8 seconds?
I would guess that could probably happen after a TIA, but fainting, it can be caused from a number of things. So you want to check it out, what's going on. Certainly, if you're concerned or if they have a history of TIA, you might want to rule out, did they just have one? Because people can kind of just drop.
Yeah, the woman did not want
Yeah.
to just.
But not as marked, not as you wouldn't see it as big. It would just, sometimes they're so subtle you don't quite notice. It's just you notice over time that their cognitive functioning is getting worse. Sometimes the TIAs are so small they don't show up on a CAT scan. And sometimes they're so small they don't show up on every MRI. They might show up on certain MRIs with certain high resolution. So we notice that stair-step progression as the result of those subsequent TIAs, but sometimes it might go like this, right? Depending on when and where and how it's happening. So that's the second most common cause. We also see in people with Parkinson's disease, we see certainly motor disturbances associated with lower levels of the neurotransmitter. We remember what a neurotransmitter is? Those chemical ferry boats, right? The neurotransmitter dopamine, which is associated with motor activity. So we see lower levels of dopamine in people with Parkinson's. So mostly we think of Parkinson's as a movement disorder. But a certain percentage of people with Parkinson's will also develop a dementia related to the Parkinson's. It tends to happen later on in the disease process with Parkinson's. So not for the whole span of the disease. We also see it's getting better and better. They're getting better and better at identifying it and diagnosing it. Lewy body dementia, L-E-W-Y, B-O-D-Y. That's just the name of the protein that they find in the brain. They're called Lewy bodies.
Could you repeat that, please?
Absolutely, Lewy body dementia. And Lewy body dementia often gets misdiagnosed for Alzheimer's, and it often gets misdiagnosed for Parkinson's, because we see lower levels of the neurotransmitter acetylcholine. Does anybody remember what that does?
Dementia slows it down.
Acetylcholine is the neurotransmitter associated with memory that we see decreased in people with Alzheimer's. And it also, so Lewy body, we also see lower levels of acetylcholine, and we also see lower levels of dopamine, which is what we see in people with Parkinson's. So people with Lewy body have cognitive symptoms that often look like Alzheimer's and motor symptoms that look like Parkinson's. So a lot of times people will call me and say, you know, they have Parkinson's and dementia, and I say, have they ruled out Lewy body? Because they could have Parkinson's-related dementia, certainly. They could also have Lewy body dementia, because they have the motor disturbance from the lower level of dopamine, and they have the cognitive disturbances from the lower levels of acetylcholine. With Lewy body dementia, we also see marked visual hallucinations.
Ooh.
That's not to say that people who are having hallucinations automatically have a diagnosis of Lewy body, because people with other types of dementias can also have hallucinations. Remember I said Alzheimer's disease affects the whole brain, so eventually they're going to run the gamut. But with Lewy body, they tend to be pretty intense, and they tend to be visual in nature. So if you've got someone with intense visual hallucinations, a tremor, and cognitive impairment, I would want the doctor to rule out Lewy body. The other thing that's really important to know about Lewy body dementia is that folks with Lewy body dementia can't tolerate certain medications that are prescribed often for folks with Alzheimer's disease. A lot of the antipsychotic medications, they could go into neuroleptic shock if they give it to somebody with Lewy body dementia. So when the doctors say, well, they're 85, what do you expect? I take issue with that because I think it's incredibly ageist, because if you brought someone in who was 35 with those issues, they would be all over it. But B, it's important to know what you're working with so that you can have these realistic expectations in the context of the diseases. But also, we don't want to give someone medication assuming they have Alzheimer's and put them into neuroleptic shock because they have Lewy body. Does that make sense? So a lot of people who have those adverse reactions or who have paradoxic reactions, you know, oh, we gave them Haldol and it got worse. That's really, it's not as common as you would think, according to the, you know, my go-to pharmacist at UCSF Memory and Aging Center. It's not as common as you would think if in people with Alzheimer's. But if you're giving that medication to someone for whom it's contraindicated, like somebody who has Lewy body dementia, then you might see some adverse effects. So that's where having a good diagnosis can also be helpful. We have I'll just name a few other ones. I want to get us to our break. I see a lot of people kind of scooting around in their seats. I think we need a little bit of a break, and then we'll come back and get into the meat and potatoes of the communication. But I'll name a few of the other diagnoses and give you a quick and dirty description of them, because you might run into them. We've covered the major players that you'll probably run into. But we also see dementia caused by traumatic brain injury. I mean, I'm talking about dementia in that umbrella term, right? Impaired intellectual capacity, lack of ability to use logic and reasoning, and memory loss. So that, like stroke is an acquired brain injury. Traumatic brain injury is that a fast-moving object hits your head, or a fast-moving head gets suddenly stopped and has damage, right? So extent and location are also key for determining after effects of a brain injury. So if somebody gets hit in their frontal lobes, you're going to see changes in that executive functioning, lack of inhibition, poor judgment, personality changes, emotional lability. Remember, lability just means quickly changing. You may also see some physical effects. You know, if there's paralysis or contractures, those sorts of things. People with traumatic brain injuries kind of sometimes run into the same, families run into the same sort of thing as folks with loved ones who've had massive strokes, where they might rehab physically all the way, but still have some residual personality changes that stay, or some apathy or depression, those emotional changes that are normal after effects, but not always assessed. So that's good for us to know if we go into someone's home and they're caring for their 30-year-old son who was in a car accident when he was 25. Well, we think about folks caring for people with cognitive impairment, we always think about older folks, but I've got a lot of parents caring for adult children who've had brain injuries.
Right. With the same symptoms, with
Yeah,
relatives.
similar, yeah. And they can last a lot longer because they start younger. So, if we go into someone's home whose loved one has had a brain injury, we might be prepared for those emotional changes that happen quickly. We might be prepared for them to be apathetic and not want to do all these wonderful activities we've got planned, right? Doesn't mean it will necessarily turn out that way, but if it does, we won't be shocked, because we've got realistic expectations in the context of that brain process.
Is there a doctor in town that specializes in this?
There are some neurologists in town, and there are some psychiatrists in town. Psychiatrists are helpful for medication. Not necessarily in the same way that they would specialize at these clinics. You're not going to get down to, the neuropsych testing, the neurological testing, all of those things. I recommend people go to either UC Davis Diagnostic Center, there's one in Sacramento and there's one in Martinez, or UCSF Memory and Aging Clinic. It's a big schlep, but most people I've talked to, in fact, I think everybody I've talked to who's gone has been grateful that they went. You get a really wonderful, multidisciplinary team working with you.
So Davis would definitely use a body to look into these things.
Absolutely, absolutely.
Because I've donated mine to them.
Absolutely.
I thought that anybody wants to look at this mess. They'll learn something.
You're brave.
It is, they'll build
Get me there.
insurances, they'll build Medicare, you don't need a referral. They prefer a referral because they want to work with your doctors here, and if you can get any preliminary tests done here that they don't have to do, it makes the process there faster. But if your doctors, sometimes doctors will say, I don't think it's worth it, I don't think it's worth it. They don't require the referral. You have a question?
So Jean actually raises that issue that you're on right now, which is the level of training in the medical communities generally, and how they are in different regions, including rural,
Absolutely.
poor regions like ours. So I don't know if,
So access is a huge issue.
right.
Yeah, yeah.
And would that affect a volunteer advocacy effort, working with people in terms of getting appropriate medical care?
Well, I think you, in terms of your role as a volunteer going in, you might be prepared for families to be a little more stressed because they don't have
Knowledge.
the same support network as if you're working with a family in San Francisco, right? Or a family in Santa Rosa, or a family in Sacramento. Families in those rural areas have less accessibility. So to get to the, I work with families in Lake County who have to drive down the mountain with their 97-year-old confused person trying to pull the emergency brake the whole time just to see the doctor. And somebody in Santa Rosa might have a hard time getting their loved one in the car, but once they do, it's a 5-minute drive across town. So both are difficult, both are valid stressors, but just different manifestations. And so certainly be prepared for folks to be more stressed. I'm not recommending you go to people's houses and say, you really ought to get a good diagnosis.
Right.
I'm not recommending that at all.
Alexis, but I mean, is your sense that the say primary care physicians are trained at this level? I mean, it seems like this kind of training might be beneficial.
My sense is that there's a big learning curve around dementia in the general medical community, unless you're working with a specialist. And that's not to say that practitioners aren't wonderful at what they do. It's just not their job.
Right.
Yes. To be honest with you, just sitting here today, all of us might have more knowledge than the other ones. And that's why they're emphasizing now that dealing with our doctor, we are now in partnership.
Right.
Unlike years ago, that once what the doctor give us, we take it. Now we're smart enough, we learn from Alexis. We have access on internet. They give you a medication. You study the medication. If you have question with it, next time you go, you advocate for your own self and for the people around.
And one of the services that we provide at Redwood, a lot of the counseling that I do with families is how to interface with the doctors, what questions to ask.
Exactly.
What to
Not
do.
do it confrontational.
And we have a class, actually. We have a 4-week class called What's Up Doc.
I have an experience just a week ago here, one of our best doctor in town, and I brought a patient, and I can see that she's an MCI. So I said, Dr. So-and-so, I said, so that means you don't see the dementia, but you see it's between the normal aging and dementia. And I said, so that means she's under MCI. And the doctor looked at me and he said, MCI? He doesn't know.
Mild cognitive impairment, for those of you who don't know what MCI is. So mild cognitive impairment is when there's enough impairment to be above normal aging, right? We talked about normal aging earlier on, but not enough to qualify as dementia.
Right.
So in between. Most MCI cases, I think about 80–85%, eventually develop into Alzheimer's disease. But some don't. Some people just stay at MCI. Although I don't know that those statistics are always changing as research changes. It's a newer diagnosis, MCI, within the last maybe 10–15 years. So as we pay more attention to it, we might notice that more people do progress, and those statistics might change. We see some dementia related to Huntington's disease, which is another more rare, but you might run into it. We have some clients. Movement disorder used to be.
I'm sorry, what was that again?
Huntington's disease. Huntington's.
Thank you.
Or you may have heard of Huntington's chorea. Used to be called St. Vitus dance. The chorea is really big movements. Not like the tremor or the freezing that you see with Parkinson's, but really big kind of jerky movements sometimes. This is a genetic disease, so lots of times multiple family members are affected. We had a client once whose husband and all 4 children died of Huntington's disease.
Oh, wow.
So if you go into a household where somebody has Huntington's disease, be prepared for that family to be really grieving. Be prepared for that family to be, you know, afraid. Is this going to happen to me? Some adult children decide to get genetic testing because they want to know, and some don't. But there's that looming kind of fear. And the family's dealt with it for a long time. You may notice that, boy, this family seems so unorganized because they've been managing these chronic disease and multiple family members for years and years and years. So lots of things have fallen by the wayside. So there's a cognitive impairment that happens with Huntington's disease as well. Not as marked or severe as you might see with people with Alzheimer's, but certainly changes in memory, changes in reasoning, changes in ability to communicate. Some of that is physical, as their body's not able to go, you know, produce the speech. But some of the communication too is neurological. So, you know, those are kind of the ones we see most often. There are others that you might run into. Dementia related to HIV, dementia related to Lyme's disease, dementia related to
Lyme's disease, did you say? Real?
Can have a component, right? And you know, we also see people with hypoxic, anoxic brain injuries. People who, you know, my mom went in for a triple bypass and came back and was never the same since. Sometimes people have a stroke, but sometimes there's just lack of blood flow that is long enough to cause some brain damage. Near drowning incidents, suffocation, medications sometimes. I know of somebody who is taking 2 different medications, again, another medication interaction story, 2 different medications, and one was causing the oxygen not to bind to their red blood cells. So
Smoking does that also.
Their brain wasn't getting enough.
Smoking does that also.
Sure.
Increase the oxygen in blood.
So people who are diabetic, people who have advanced COPD, we might see some subtle cognitive changes. So it doesn't look like somebody with Alzheimer's disease, but still somebody who's not using enough good judgment or reasoning reliably and consistently enough to be left alone all the time.
Right.
Does it,
That's the key.
Alzheimer's ever come on fast?
I think, again, in the earlier onset, you might see it come on fast, but you wouldn't see it come on fast like we were talking about a delirium, right?
I'm talking like in a month.
I don't think so. I think we might notice it fast. I think what happens is a lot of times people have it longer than we know they've had it, and they've been able to compensate for a long time because their brain was still intact enough that, you know, you hear sometimes when people lose their vision, their hearing sharpens. So sometimes the brain can come in and compensate. The brain's amazing. But there might be a tipping point where there was a stressful incident, or they got sick, they went to the hospital, they had an infection. All of those things that are reversible can also affect someone with dementia and make the dementia worse until it's treated, right? So then, when they reach that tipping point, it becomes apparent to us there's something really wrong here. Doesn't mean the disease had a quick onset, it just means our recognition of the disease happened quickly. Does that answer your question?
And can some medications look like Alzheimer's?
Yes. Lots of medication interactions can look like Alzheimer's. That's why we want to get a good diagnosis, right? Because we might take someone to one of those clinics and they might rule out dementia altogether, all forms. They might change medications and the person might improve in functioning. If you're taking a medication that's causing your oxygen not to bind to your red blood cells, you're going to seem pretty darn confused. And if they can fix that, you might regain some functioning. Now, if that goes on long enough, there might be some permanent damage. but certainly not as bad as if you continued taking it. So that's one way. The other one I mentioned earlier was medication A was causing medication B to be 3 times more potent, and somebody was getting effectively overdosed, even though they were taking normal dosages of both medications. So we want to rule those out. Any questions so far? I know this part is kind of dry, this part's kind of long, but
Dry at all.
I think that it's really important for us to have this good foundation and understanding that not all dementias are the same. There's variability within each diagnosis depending on location and extent for some kinds, depending on onset, depending on baseline functioning to begin with. So one person's dementia is not going to look like another person's dementia. And even within the same diagnosis, might not look the same.
If we're going in and doing your function as a volunteer, just going in so that someone can have some time away from this, and that's all we're doing is being these sweet little do-gooders. We must stay away from all of that, right? Because we're not there to give medical advice.
You're not there to
or
give medical advice, no,
or
and
to
that's
tell
not
this family what to do.
correct. And I'm not recommending you do that.
Yes,
No.
so the
This
families that have this, that information is great for.
It's
But
great
the
for-
rest of
it's
us,
great for-
we need to back off from it.
You need to back off from giving that advice, but great for you to know,
Yes.
so that
Absolutely.
while
Yes.
you're taking care of the person, you have the understanding. Okay, this person has Lewy bodies, so if he starts hallucinating while I'm here with him, I'm not gonna let it freak me out,
Yes.
right? But you're not gonna say, you know, I think he should stop taking that medicine because Alexis said that. No.
Yeah, but however, because they,
The pharmacist comes out to the parking lot, to the car to you and tells you, this person you've been helping, I don't think should be taking this medication. Can you get them to can you talk to their doctor?
Oh, you
It's
say,
very difficult.
yeah, and
Because
they
they-
shouldn't put you in that
Because if you only
position,
talk to their family and their family says, how long do you want them to live?
right? Well, and
It's
that's an
very
individual,
difficult.
yeah, and you shouldn't have been put in that position. That's not appropriate for you to be put in that
Well,
position.
that was just a friend.
Yeah.